Good morning. Delighted to be here in Las Vegas. I'm also delighted that my talk is not going to overlap too much as I thought it would. I do have some disclosures, including my significant education from Intuitive last year. So I think the important take-home message today is that post-discharge surgical care is not one size fits all. And we have been treating it like that for many, many years. I think telehealth can help with this, but it is not the answer for all patients. Oh, this is awfully small. I hope you all can see this. So my feeling is that I got into this interest in monitoring post-operative surgical wounds because things haven't changed significantly since I was a resident. And I answered the phone when I was on call, and I said, I don't know if you have a wound infection. You're gonna need to come back to the emergency room so that I can take a look at your wound. And I think we still do this quite a bit. We still have a 7 to 14 day post-discharge follow-up. We don't have a personalized follow-up window. We still have the same post-op wound care instructions. There's no risk stratification. So if you're a high-risk patient, your wound might break down, maybe you have diabetes, we give you the same instructions. We give the same advice over the phone, which is come back to the ER. We don't have any proactive attempts to avoid these ad hoc emergency or clinic visits. This is despite all of the wonderful things we've just been talking about in this session. With ERAS, there's an abbreviated hospitalization. That's great, right? Well, maybe not. We have all kinds of wound care protocols that are new devices. We're sending patients home with wound vacs. They're the first to see their wounds for the first time. Is that good? Ask the patients. We have increasingly regionalized surgical care delivery. This is wonderful. We're trying to improve surgical outcomes, but how do the patients feel when they go home? My contention is that patient-centered care changes the paradigm. In the old ways, which are still current in many cases, the clinical problem is the MD's focus, not the whole person. We have office hours, we have clinic hours. This access is limited, very narrow window, whereas in a new paradigm, perhaps the patient can follow up whenever they want to, whenever they need to. The team focus was respond and repair. The team focus could be manage and prevent. The site of service used to be a building, and as you already heard today, it doesn't have to be. So as we change this paradigm, can we be more patient-centered? In fact, we can. And as the previous speaker stated, during the COVID-19 pandemic, we had a dramatic increase in the number of telehealth visits. I think this is a really nice paper from almost the beginning of the pandemic where it talked about there was this dramatic rise in telehealth visits and a dramatic decrease in ER visits as people sought to avoid coming to the hospital in the beginning months of the pandemic. What were the facilitators? Well, number one was fear. We don't want fear. We want to continue to keep the doors open, and we want to continue to care for patients. But that really was only made possible, that inflection of that curve happened when the telehealth waivers went into effect from CMS in March, and the CARES Act was initiated. So regulatory changes had to happen for telehealth to thrive. And of course, the convenience was something that we very rapidly discovered, both on the patient and the provider side, although it wasn't convenient for everyone. So what are the sustainability facilitators? It turns out that we didn't maintain this very high rate of telehealth visits, but those places that had a larger practice size were the ones that tend to retain more telehealth visits even after the initial wave of the pandemic. What are the other facilitators? Well, probably ongoing reimbursement, parity, which is an issue that we'll have to address, and obviously the patient and the provider must prefer this to the in-person visit for it to be sustainable. Now, what are the innovations that came about? Well, you already heard about post-operative video visits, but I also wanted to mention that there are also store and forward options like the patient portal that allows multimedia data sharing, including texting. And all of this is asynchronous, meaning that it doesn't have to happen at the same time in real time, but rather can be a message that's sent and then reviewed and then returned. Remote patient monitoring is a whole nother issue. Remote patient monitoring truly is being able to get patient data, vital signs, and other important data from patients directly that is uploaded into the electronic health record. And how is this facilitated? Well, for example, the UNMC Center for Telehealth, which is the other Center of Excellence for Telehealth in the United States, aside from MUSC, has this wonderful graphic where they depict the relationship between the data, who reviews it, and how it is passed back and forth between patients and the telehealth center. This is a very important concept because it's not just direct to the provider that initiated the care with the patient. It's a whole nother set of providers that are involved in the patient's care. And some of this is multidisciplinary care coordination, really. In the last few minutes of my talk, I'll just mention that what we did during the pandemic was we leveraged a telehealth opportunity that was happening in real time. Our Center for Telehealth actually started using Epic MyChart to be able to communicate with patients who are COVID-19 positive and monitor their symptoms at home with the use of a questionnaire that was delivered through MyChart. We took that paradigm and we focused it on post-operative care and building upon the work that I'd done at the University of Washington doing post-operative wound monitoring. We initiated this whole process using a questionnaire through MyChart and actually getting the patients to submit wound photographs on a regular basis. So we leveraged these institutionally accepted data streams, not adding a new app or a new communication method, using what we already had. And importantly, we included that telehealth nurse in this triangular conversation between the patient and the physician, acknowledging that we didn't want to overburden the physician with a lot of normal data. But telehealth is not for everyone. Obviously, there's the danger of patient disparities, who doesn't have access to digital data or broadband or education. And then there's the issue of provider acceptance. It's a bandwidth problem, an inability to take on these additional communication streams. And are we going to have to add additional services within a health system to be able to cover this? It's also an education and culture problem. This is not the kind of care delivery I like. This is not what I signed up for when I said I wanted to be a surgeon. And those are issues that we're going to have to address together. But it's time to evolve our post-op, post-discharge care. While we don't walk around with black bags anymore, we can meet patients at their home. So the take-home points from my talk today: telehealth innovations can improve post-discharge communications and care continuity for some surgical patients. And telehealth access and adoption are facilitated by revenue streams, like it or not. And consider strategies to maximize both efficiency and personalization is really the way forward. We need to take patient preferences and access into account. Thank you very much.